Thank you for inviting me to give you this presentation. As you said, healthcare workers, psychological distress and moral injury as a public health priority. Even though this is not a new issue, it has come to the fore as the result of the pandemic. Next slide, please. Shocking images of distraught and exhausted doctors and nurses fighting to save the lives of countless COVID-19 patients in extremely difficult and challenging conditions. And these healthcare workers face many of the most difficult decisions of their career when the hospitals became overwhelmed and equipment ran out. Who to ventilate? Who to give a bed to? Who to turn away, knowing that they may not make it through the disease? These decisions force us into ethical and moral dilemmas that was intensified by the severity of the consequences. These are life and death decisions that healthcare workers are forced to make. Making these decisions compromise our ethical values so much that they cause deep psychological pain and shake the foundations of how we view ourselves as individuals. So what is moral injury? Next slide, please. It is defined as the lasting psychological, biological, spiritual, behavioral, and social impact of perpetuating, failing to prevent, or bearing witness to acts that transgress deeply held moral beliefs and expectations. It can be caused, next slide please, by acts of commission, where we feel we are perpetuating actions that strongly clashes with our own moral beliefs, doing something that goes against your beliefs, our beliefs, or acts of omission, where failing to do something in line with our beliefs, where we feel that we have not done what we could have done under the circumstances. There's a sense of knowing what should be done, but cannot do so for reasons beyond our control. And also a sense of betrayal, where we feel betrayed and unsupported by who we trust to support us. Remember, for a healthcare worker, next slide please, it is first and foremost, patients' needs comes first, and primum non nocere. First, do no harm. Next, and consistently, next slide, and consistently failing to meet patients' needs has a profound impact, next slide please, on the psychological well-being of the healthcare worker. The term moral injury was first coined in 1990s to describe the painful sense of moral disorientation felt by the military returning from war. It is later used to describe the experience of healthcare workers facing such challenging and similarly distressing circumstances. It describes the challenge of simultaneously knowing what care patients need, but unable to provide due to constraints that are beyond our control. Next slide, please. So we often face with red tape. So knowing what we need to do, but unable to do so because of a lot of constraints that we're faced with. Next slide, please. It is a spectrum, all causing varying degrees of discomfort. Moral distress, where the right course of action is known, but we are unable to complete it due to institutionalized obstacles. Moral uncertainty, where there's questioning and unease because we are not sure of the right course of action. Or moral dilemma, where there's multiple conflicting but morally justifiable courses of action and where we are not sure ourselves which course of action to take. Next slide, please. And remember, there are two types of ethical dilemmas. The first one is unavoidable, such as diagnostic dilemmas and terminal illness, where we feel hopeless and impotent. And then there are the avoidable ethical dilemmas such as institutional, financial, and social constraints as the result of austerity measures. And the moral dilemma, the avoidable ethical dilemmas are the ones that causes the moral injury and the moral distress. Next slide, please. It is a continuum of harm. It ranges from starting with moral dilemma, where you're not sure what to do or which course of action to take, to moral distress, where you know the right thing to do, but you're not able to do it, resulting in moral injury when you're subjected to repeated or prolonged inability to meet the patient's need. And beyond that, it can result in burnout, but it can also coexist with pre-existing burnout. So burnout can coexist or can be as a result of moral injury. Next slide, please. So as I said, it's a continuum. It can go back and forth, but it can also, when it became severe enough, you become from emotionally and morally engaged person to become a morally numb. And that's when you are labeled as burnout, when there is disengagement. Next slide, please. Okay, so how do you distinguish between those ones? The moral distress, as we said, is constrained from doing what is right. And it causes, the symptoms are unease, discomfort, anger, frustration, feelings of powerlessness, and may even present as palpitation and anxiety. It is often acute, and it can result in moral injury if it's prolonged or severe. And the definition of moral injury is the lasting psychological impact and so on. Any resulting guilt, shame, anger, disgust, social withdrawal, ruptured identity, and existential crisis, which is a chronic problem and can result in burnout. And burnout is a completely different story. It's a syndrome of emotional exhaustion, loss of meaning in work, and feelings of ineffectiveness, as well as emotional detachment. You feel numb, you feel carelessness, you're disengaged, you're exhausted, and you may treat people as objects rather than as people. Also a chronic condition, and the result of that is often medical error, malpractice suite, dissatisfied patients, increased staff turnover, addictions, and unfortunately, suicide. Next slide, please. Any moral injury, the sadness of that is that it presents with massive feelings of guilt or shame. There's self-destructive impulses, there's loss of religiousness, there's loss of faith or hope, there's loss of trust, lack of purpose, self-blame, anxiety or depression, substance abuse, and other physical symptoms such as sleep problems and eating problems. The fundamental issue is a mistrust. You feel broken or weak. You believe that the world is a dangerous place. People cannot be trusted or counted on. And the worst part is when you believe that you yourself, I cannot be trusted. It's a fundamental shift in self-perception, which is injurious to the soul. And this is why we need to address it as a matter of priority, as a matter of urgency, because this is very destructive. Unlike burnout in a different manner, this injures the soul. Next slide, please. And the situations that increase your chance of developing moral injury are events where there's loss of life to a vulnerable person, somebody that you can see that is vulnerable. When leadership is perceived as supportive, or the sense of betrayal. When there's overall lack of social support, so social isolation, or people are unprepared or unaware of the consequence of the decision. So when they make the decisions and they see the consequence that are totally unexpected, they can suffer moral injury. And also when it's in conjunction with other traumatic events, such as COVID-19 or the earthquakes or floods or whatever other traumatic events, it increases the chance of moral injury when you find that you cannot do what you feel that you could have done, or you did something that are injurious to a person during the process and you feel that you have done somebody wrong. And that's very different and that may result to physician burnout. Next slide, please. Let me see. Sorry, I've lost you. Yeah. Okay, so the consequence of physician burnout is even more severe. You produce, and unfortunately, lots of consequences to your work situation and to yourself. There's a decreased patient care, decreased productivity, increased medical errors, resulting in more morally injurious events. You create toxic work environment for people around you. There's poor quality of patient care and satisfaction. There's increased rate of leaving your work and premature retirements. There's increases in healthcare costs because you are just not putting your attention on preventing, eliminating wastage and other important issues. And also, as a result, there is self-harm, addiction, suicide, and increase in car accidents and other injurious events. Next slide, please. Okay, so how do we cope with moral injury? So while the ultimate responsibility of preventing moral injury actually rests on the organizational decision makers, the individuals are often forced to deal with the consequences on their own. So we can't, as we discussed, it is the reason why we developed moral injury was prolonged exposure to constraints, which enables us not being able to do what we feel is the rightful thing to do. So that is a lot bigger than the individual can do. But unfortunately, when there is moral injury, the coping mechanisms has to come from the individual first. And so the first one is to confront it. To confront it as an individual, you need to, without confronting it, you cannot deal with it. You have to listen to your pain, because denial is a very comforting mechanism for coping and enduring. And so we often deny that there is a problem. And so we need to confront it and start dealing with it. The second is to engage in soul care. Moral injury has been described as wounding of the soul. It requires a special kind of attention. It's unlike self-care, where we talk about looking after yourself, eating well, sleeping, doing all the right things that's physically helpful for you. Self-care, which is often talking about pampering yourself or looking after yourself, indulgences often don't reach the soul. So how do you look after your soul? One of the greatest releases of emotional pain comes from an honest and open conversation with a trusted professional. Look for a coach or therapist or a mental health professional trained in dealing with these trauma responses that can help guide you through the exploration of the pain you're feeling, because until then, you cannot release it and you cannot deal with it. The bitterness of moral injury can also often make us crave revenge, such as destruction of property or whatever way you want to deal with the injury that you felt. But any satisfaction from that will be short-lived. So don't give in to that. No matter how justified you feel, you are still compromising the very values that were injured to begin with. So don't give in to such impulses, because you are just deepening your injury. Learning to self-regulate is critical to steering clear of acting impulsively. Next is to choose forgiveness. Now we must remember, forgiveness is not the restoration of trust. It doesn't require that you have to be in a close relationship with the person or the system that you're forgiving. It simply means that you yourself are letting go of your bitterness and desire to retaliate for the harm that you have that's incurred by you. It means letting go of expectation that the person or the organization will show any remorse for having caused harm to you and to the patient, or to any other event that you feel has caused moral injury. And one of the most painful discoveries of grappling with moral injury is the harm that we feel that we have inflicted on the patient. So not only the act of omission, but the act of commission. So we may have done things that we feel that wasn't right to begin with on the patient. We have done procedures that were not beneficial to the patient, or things that we afterwards regret doing. And that leads to a lot of guilt, a lot of shame. And we need to actually look at it and forgive ourselves and shed that shame and that guilt. It's not easy. It often requires a lot of therapy sessions, and it often requires trained professionals to help you deal with it. And the main thing is that we cannot heal in the same situation where the injury keeps occurring. So we cannot restore our own conscience when we are in a situation where we're continuously violating our values. So sometimes, even though we can still do good work for the organization that's causing us to violate our values, and we can help create a better working circumstances, sometimes by continuously violating our values, we actually deteriorate. So during that time, when we look at these situations, it might be unavoidable to change, to leave the situation organization, to change our situation. Next slide, please. Okay, so although moral distress may be unavoidable in healthcare, moral injury and burnout are not. So to prevent and repair moral injury and stop its progression to burnout, we must actually deal with the healthcare leadership, must acknowledge that the problem is not individual weaknesses, it's not the individual healthcare workers, but rather systems and contexts that need to be reformed. And so talking about individual strengthening of resilience, which we've been talking about for a long time, simply will not make much of a difference. Okay, so in situation of moral distress, the solution may be to remove the inciting situations, to do a system reform, strengthen moral identity through community, so everybody working together to decide what are the values, and cultivate moral resilience. And to prevent moral injury, it needs institutional level structures reform, community and peer-based intervention. So it's a group effort. It's not an individual effort. Individual effort achieves very little in these instances. And to prevent burnout, you can give the person sabbatical or intensive therapy for addiction or depression and change your career. So compared to burnout, moral injury requires a much bigger response as compared to burnout, where you need to deal, it is also a systems issue, but you need to deal with the individual first. Next, please. All right, so cultivating moral resilience allows clinicians to overcome moral obstacles in their practice and mitigate downstream effects of moral distress. However, no matter how resilient the healthcare worker is, they cannot simply indefinitely sustain excess workloads with minimal resources. So hospital administrators and the public health system must therefore prioritize staffing and supply shortages as matters of first importance. Structural reforms are also necessary. You know, healthcare settings can be highly chaotic, and chaotic work environments are associated with stress and a desire for people to actually leave. And many people have done so. I think 20% of our workforce have left the healthcare setting over the last couple of years. And not only that, many institutions have seen a massive rise in patient volumes over these last few years, or over the last decades, even before the pandemic, without a proportionate increase in staff or workspace, which translates into compromised care of patients. Patients also complain that their doctors and nurses do not spend enough time with them. So reforms to increase patient-facing time and reduce patient volumes and offloading of non-medical tasks to support staff can increase both healthcare worker and patient well-being and allow clinicians and nurses to concentrate on practicing high quality and ethical medicine. So what can we do? Next slide, please. Oh, before we go to that, combating austerity, which is resource constraints. Now, austerity, we often think that we are in a country that have resource constraints. In fact, resource constraints occur throughout the world, including first world countries. And we, as clinicians and as healthcare workers, need to remove the us versus them mentality and work together. So as clinicians, next slide, please. We feel that there is a failure of the healthcare system, that doctors are focused on providing better patient care, which is not mirrored by the other side, and that doctors want more support, more staff, less paperwork, and fewer restrictions, all solutions that will require added resources. On the other hand, next slide, please, the hospital management and the medical funders and administrators in the government feel that there's a failure of the healthcare delivery system. So they are providing healthcare, but it's not being delivered to the public. And they regard themselves as healthcare's financial stewards. They want to curb the healthcare cost inflation by decreasing wastage, inefficiencies, and unnecessary services. And both are right. And so to combat these resource constraints, to combat austerity, we actually need to remove the us right and them wrong mentality and actually work together. Next slide, please. The problem with the healthcare systems are quite multifold. Communication, poor communication, and often the unilateral decision-making without consulting the people that are actually working within healthcare. As we all know, infrastructure and lack of resources, shortages of essential equipment, supplies, infrastructure to ensure safe patient care, time, the long work hours and excessive workloads causing exhaustion and impaired ability to think, to make decisions and to think clearly. Excessive time spent on administration and paperwork instead of spending on patient care. Administrative burden, as I said, excessive administration burden and inadequate time to spend with patients. And lastly, personnel, inadequate staffing issues leading to excessive workloads and inability to give quality patient care. So how do we deal with that? Next slide, please. We need to solve these healthcare system failures to take action against moral injury and clinician burnout. and approach professional well-being. So the first thing that we can do is, next, invest in research. More research and data is needed to combat causes of healthcare inefficiency and clinician distress. We need to know where are the inefficiencies and what is causing clinician distress. We often talk about that the system is not working, but what is not working, and what is it that we can do to combat these inefficiencies and these failures in the system. Next. We need to create positive learning environments. We need to be learning-based rather than blame-based. So we need to be problem-solving. When there is an issue, when somebody reports an issue, when somebody reports a problem, we need to take that and see and deal with that in a learning manner. What can we do? What can we do better? What is it that, instead of blaming somebody and saying, you need to, the hospital administrator is at fault and didn't do the job properly. Rather than doing that, let's bring solutions on the table and says, no, this is not working. What is it that we can do to make it better? Please bring solutions rather than blame. Next. We need to create positive work environments, create healthy and safe work environments, create an area of psychological safety that people can speak up without being, we just have to take that Rahima Moosa example. You know, we need people to be able to speak up about problems, so that by raising awareness of problems, we can, without awareness of problems, we can't solve the problem. Okay, and then to have supportive relationships between different departments, between different levels of staff, between administrators and the healthcare workers. Next. We have to enable technology solutions. We have the ability to utilize technology nowadays, and using technology and data to facilitate workflow and decrease the time spent doing all these administration work and doing all the unnecessary work that could be done by machines or by AI, and allow nurses and doctors to actually spend time with patients, because that's what they are there for. Next. Using AI and using technology to reduce administrative burden, so that the people that are qualified to do the medical and healthcare work actually do meaningful and purposeful work, rather than filling in papers and filling in forms or punching in data. You know, you can always employ support staff that are not medically trained to punch data. And that's what we need to, it needs to be a mind shift to do that. We can have support staff, we can have non-medical staff working in the hospital to do these paperwork. It doesn't have to be nurses doing it or doctors doing it. Next. And provide support. I think that stigma of mental distress, the stigma of moral injury, of psychological distress should be removed, because we now know data are showing that majority of the healthcare profession are suffering some sort of distress, and we need to remove the stigma of that and encourage help-seeking behavior, and to provide easily accessible support, so they don't have to go out of their way when they're already limited by restful time and self-time, me time, to go and seek mental health support. Next slide. And so, not only beyond fixing the healthcare system, we also want to build the healthcare worker. We want to build professional well-being, because that's just as important as solving the system. So next. As we said, give meaning to the work, take away things that is unnecessary, things that are non-meaningful, things that can be done by people that are, you know, we spend so much money training our professionals, training our healthcare workers, and they end up filling in forms and punching data. We need to take that away and allow them to do what they do best, which is taking care of the patient's needs and looking after them. Next, we need to create healthy work environment, psychological safety, and the culture of learning teamwork. That has to come from the top. It has to come from the whole group together. It has to be a joint effort, a culture change within the environment. Next. This is very important. We need to spend time as a group, as an institution, as a medical group, or as a country, to discuss what is it that we want out of a healthcare system. We have to align our values and expectations, and to prevent moral injury. It is about communication. If we understand resource constraints, we understand that there are limited resources, we understand that. But if we all know what we're working for and what is expected of us, and how to use this resource in a manner that aligns with everybody's value, people won't feel that they won't feel distress morally. They don't have ethical issues with it. It's communication and alignment of values. Next, flexibility and autonomy. So it needs, so often major decisions in the healthcare sectors are made by people high up, by people that are not working in the field. And I think it's extremely important to have input from the people that are actually working in the field and their involvement in the strategy of the way forward and in decision-making processes, which are going to affect them and how they work in their work environment and how they treat their patients. To have the ability to be involved will take away a whole lot of the moral distress that they are experiencing. Next. And very important, we need to enhance the relationships, not only between co-workers, between different groups and subgroups of doctors, between different specialties, but also between the administrators, colleagues, and patients, as well as the public health structures. When there is a good communication and good supportive relationships between all that, then things can get done efficiently without too much red tape or constraints. Next, we need to build into, and this is something that have not been able to do, is to allow the healthcare workers to have integration of professional private lives. You know, we are so short-staffed that the healthcare workers are working long, exhausting hours, and that they are not able to have an adequate work-life balance. And we need to find ways to combat that, and including adequate staffing and reasonable work hours. And that's something that is a priority. It's not something that we can say, okay, later, until somebody burns out, until somebody gets sick, until they leave the profession. It's got to be done now. And lastly, next, we need to give adequate rewards. It may not be just monetary rewards. It's acknowledgement, praise, gratitude, appreciation, and also, importantly, feedback. I think we need feedback on how we're doing. We need feedback from the top down, and we need feedback from the bottom up. So people in positions of power need to know how they're doing and how they can improve. And people down there need to know how they're doing and whether their work is aligning with the institutional strategy or on the way forward. So feedback is one of the most important things that I don't think that we put enough emphasis on. And lastly, I think there are additional resources for fostering communities. So we need to build communities, not only in these relationships, but among the healthcare workers, such as unit-based ethics conversations. We need to have group conversations about our experiences in a traumatic event, but also our values. What are our values, and how do we come to a common value system? We can have a SWOT rounds, which is an interdisciplinary group conversations. We can have moral distress map, where we map out what causes us moral distress and actively do things to alleviate that. And we can actually also integrate maybe spiritual or religious personnel to help us with the individual processing of the moral injury. Peer support, group conversations among colleagues, all help. So this is a group effort. It is a group effort not only from within the hospital, but also from as high up as government, as high up as a public health structure. And it is a priority, because without doing this, it is just getting worse and worse. And we already, personnel resource constrained environment. And by allowing our healthcare workers to deteriorate, it's just simply wasting resources, let alone causing more moral injury to all of us that are working in that environment. And I think that's the last slide. Thank you.
The challenges just seem so huge, though. Thank you for the work you are doing. How do you keep going personally?
So for me personally, I feel so. Yes, you're right. The challenges are huge, and so often when we look at a mountain of challenges, we feel demoralized. We feel that we are incapable of dealing with it, and we don't even start. So the way I deal with it is, how do you eat an elephant? One mouthful at a time, right? Mm-hmm. So what I do is I look around me. I start with what is around me. So I work in a theater environment. And so what I do is I personally make sure that I walk the walk and talk the talk. So I would treat my colleagues the way that I would like to be treated and the way that I present it. So I would create a psychologically safe space, and I would make sure that we get to know each other personally. We support each other. We chat through whenever there's a traumatic event. We actually have a group huddle and we talk about the issues. And when there are challenges, for example, when we're running short, say, for PPE during the COVID time, we would discuss how we're going to deal with this. And we will find solutions of our own if we can't find solutions from the institution or from the hospital. So we help each other surmount challenges. And by doing it a little bit, a small step at a time, a little bit at a time, I find that we feel constantly that we are in control. And I think the worst part about seeing a mountain of challenges is that we feel so helpless and we feel that there's nothing we can do. So by doing little things and making sure that we are in control of the little things that we can change, we always feel in control. We always feel that we have the power to change things, and that's how we move forward.
The next question we have is from our other attendee, who says, what role does corruption in healthcare systems play in moral injury, and what can we do about it?
Yeah, so that is a very difficult issue to deal with, because I think it causes the worst type of moral injury when we realize that the reason why we can't take care of our patients adequately and we have so much resource constraint is because of corruption, where that's wasted somewhere else could have been used on saving somebody's lives. And that causes a huge amount of resentment, anger, and injury. So what can we do about it? I think we, firstly, on a small scale, we can tell ourselves that that is not in our control. So firstly, corruption is not in our control. What we need to control, what we can control. So make sure that there is no inefficiencies, there's no wastage. We maximize what we can do within the environment that we work in. We teach our staff to do the right things, to decrease inefficiencies, to maximize everything. So, for example, sometimes, you know, you see in one theater case, one single person would be using like 4 sets of gloves because they're taking it off, they're talking on their phone, and then they're putting the gloves back on when they need to, and then they take it off to finish what they need to do. They take off their gloves and then they go back on their phone, right? So then we explain what that can cause, what they are doing that's creating more constraints, more resource constraints, and make people aware of what they can do to improve systems. So that's one thing we can do on a small scale. Obviously, on a bigger scale, you can go and vote. you can if you are that way inclined, you can get involved in structures. You can get involved in forums where you can make a difference. You can have your voice heard. You can sign petitions. So there are a lot of things at different levels we can all play a part. I know that ultimately we probably feel that we're not making much of a difference, but by doing little things within our circle of control, we can make a difference. And if everybody does a little bit around their circle of control, we can actually make a little bit of difference. I know it's not the big difference that corruption, we can't get rid of it. Maybe one day we can vote it out, but yeah, it's a difficult question to answer.
Another question we have is from Emma, and she says, what can our faith communities do to help our healthcare workers with moral injury?
Yes, so the faith communities can do a lot. So obviously, if the healthcare worker is religious and they truly gain comfort through speaking to because remember the faith communities are work like peer support systems. They work like mentors, you know, the priests or the imams or the rabbis. They can work as mentors to and guide people along these difficult. So you don't always have to go to. Some people find more comfort by speaking to these leaders, faith leaders, through as more healing than it is to speak to a mental health professional that they might find very depersonalized. So yes, they are. So obviously it works better for people that are truly religious and they have somebody that they can look up to. They have faith leaders that they believe in and that they can consult in. Not everybody has that privilege. So yes, I think we need to bring them in to help as much as you can. Obviously, you can't force it on people, and which can happen. You must allow individual preferences, but they do play a big part. You know, during COVID, I found that prayer groups, we had a denominational prayer group that just sort of like almost like a spiritual sing-song together really helped during the time of distress. It really did.
I have a final question. Not sure if you'd be able to tackle this one.
Yeah. So we have all the doctors that have gone to.
Where are they?
Obviously not in South Africa. They've gone to other countries. So, and Mr. Grass Greener. You know what? I'm very blessed and lucky that my medical school class of 200, out of that, more than 3/4 of these 200s are part of a WhatsApp group. We have our class community WhatsApp group. And within it, we communicate, we help each other, we contribute, we support each other, we tell each other news from different countries, and it's fantastic. So we have countries, obviously, a lot of our healthcare workers have gone over to Europe, to Oceania, to Canada, to other countries. It's not always greener on the other side. They have their challenges, very different challenges. They don't have perhaps as much moral injury in terms of, say, corruption, and difficulties in living environments such as Eskom. But they have just as much austerity measures, surprisingly enough. And UK has introduced quite severe restrictions on what you can use and what you can, what is available. And the workers there feel as resource constrained almost as we are here. It's just that the infrastructure is a lot better. So yes, depending on where your context, you can feel just as distressed or morally sort of injured as you are in a very deeply sort of restrained country. So people in Africa who may feel that they have nothing and have nothing to work with, they often are the ones that in fact, feel a lot more sense of achievement, because their little bit makes a huge difference to the people that really don't, just needed that little extra attention. So even though we feel that we are resource constrained, we need to look on the positive side. We so often look at the negative side of what we cannot do. We need to look at the positive side and look at what we can do that can make a difference. And so often, just that little bit makes a huge difference to the people that already have nothing.